Good afternoon, everyone. My name is Maya Luria with TMC for Seniors. And today we're back onto our brain health topics, and we're going to be talking about cutting edge solutions for aneurysm care. I have Dr. Jessey Chugh with me here. He is from Center for Neurosciences. This is a very exciting topic. We have not discussed this before, Dr. Chugh, and so I'm thrilled to have you here to sort of share about these innovative ways that you are helping with aneurysms. So welcome. How are you today?
I'm doing well. Thank you for having me. Good afternoon, everybody.
Great.
My name is Jessey Chugh. I'm one of the vascular and brain tumor neurosurgeons at Center for Neurosciences. I've been at the practice now for over a year and a half, and a big chunk of my practice is aneurysms. Probably, I'd say 40 to 50% at this point. And as a vascular neurosurgeon, I'm able to sort of train to treat aneurysms in a variety of different ways, both doing the traditional open surgeries, what are called craniotomies, that may ring a bell to you guys, versus more of the recent techniques that are what we call endovascular techniques. So those are treating through the blood vessel themselves, and I'll kind of go over some of the different treatment modalities that we have in this day and age. And so basically when we start out, the discussion is, well, what is an aneurysm, or in particular, what is an intracranial aneurysm? And when we're looking at these are what we call basically abnormal dilation, or we call dilatation of cerebral arteries. Hopefully this pointer works.
The laser pointer won't pull up on the.
Oh, it won't pull up. Okay. Well, was the mouse? Yeah. Okay. Good. So when we think of these aneurysms, there's two, common types of aneurysms. One is called a saccular aneurysm. This is by far the most common one that we deal with on a day-to-day basis. And this refers to when there's one side of the blood vessel wall sort of ballooning out, and that's probably the easiest way to to think about it. If you imagine it's a hose, right? One side of that hose weakens out and it balloons out, and that's what we call a weak point, and that's what an aneurysm is. Now, an aneurysm does not imply that it's a bleeding event. Okay, an aneurysm just means that there's a structural problem in the blood vessel, in particular structural dilation. Okay. And the other type of an aneurysm that we'll occasionally encounter is called a fusiform aneurysm. Basically, all that means is instead of one side of the blood vessel wall, the entirety of the blood vessel wall, all three, essentially a 360 manner, is abnormally dilated. Okay. So, but by and large, the ones that we see, the ones that I treat, are the saccular aneurysms. These tend to have a higher rupture risk than these fusiform ones. Okay. And so it's important to know that vast majority of these aneurysms are unruptured. Okay, so and vast majority will not cause symptoms. Okay, so in this day and age, there's there's a lot of scans being done of the head, whether it's CT scans, MRIs, MRAs, CTAs, and that's leading to a lot of what we call incidental aneurysms being found. Okay. That basically means that these aneurysms are not the cause of what's actually prompting the scan for being done. Okay, so whether you're having headaches or dizziness, vertigo, things like that are almost never related to these aneurysms. Okay, these are by and large incidental. Okay, now it's important that when we do find them, well, then we have to figure out, is this something that we can safely watch? Is this something that should be treated? And that's a discussion that I have, kind of on a daily basis with my patients. And there's a lot of factors that go into that discussion. There's certain things like smoking, high blood pressure, family history, certain genetic disorders, all things that, comprise into this, quote unquote equation that goes in that helps me quantify what the rupture risk is. Okay, because if it's an unruptured aneurysm, right, then we have to basically determine, well, what are the risks of this aneurysm bleeding over the next 2 to 5 years? And then we talk about, is this something that we can safely watch, or is this something that we ought to treat? And the reason it's important that these aneurysms be at least watched or the discussion be held early is that it is such a morbid event when an aneurysm does rupture. Okay, that could be a life-threatening event, that we always try to, err on the side of caution and really try to stay ahead of these aneurysms, because we want to prevent them from rupturing, because that can be a major and a life-threatening event. The prevalence, this number is probably being underestimated, to be honest. There's some literature that is estimating this to be closer to 5 to 7, maybe 5 to 10% of the population, walking around with aneurysms, and a lot of them, we may never know, right? There's a 2 to 1 female to male predilection. There's a lot of theories about why that may be. And ruptured aneurysms generally account for about 5% of all strokes. Okay? But even though this is a small percentage, the risk and the high fatality rates and the high morbidity meaning the significant amount of damage that it causes to the brain, that even this 5% has a major impact on our healthcare system, on a patient's life, on the families, and all those things. So it's a very important consideration. So what happens when an aneurysm ruptures? Okay, this is what leads to what's called a subarachnoid hemorrhage. Subarachnoid hemorrhage is basically bleeding that occurs generally at the base of the brain, so it's not actually in the brain itself, although some aneurysms, depending on location, can cause bleeding in the brain. But by and large, they cause what's called subarachnoid hemorrhage. That's bleeding in the subarachnoid space. And the classic symptom that's fairly uniform is what we call a thunderclap, or the worst headache you've ever experienced. And this is not like, if you have migraines, you may get a migraine, or you may get a worse, headache here and there. This is definitively the worst headache anybody could ever experience. It's almost like getting hit, in the head with a baseball bat. And unfortunately, if there's a severe enough rupture, that's usually followed by loss of consciousness, depressed mental status, inability to protect your airway because the pressure in the head can build up, quite rapidly. So this is a very different situation than having, a headache kind of peak here and there, or sort of fluctuates. All those are not related to this. This is a very unique and distinct phenomenon. Unfortunately, because of the severity of this nature, 15 to 20% fatality even before arriving to the hospital. And unfortunately, some people don't make it to the hospital in time, because it is such a rapid rise of what we call intracranial pressure. Okay, as long as patients are able to make it to the hospital in time, that's when the treatment process is started. Okay, a lot of times that involves doing emergent procedures at the bedside to alleviate the pressure in the brain. But unfortunately, some don't make it to us in time. We're looking at aneurysm surgery, aneurysm diagnosis, all these things. This is sort of just a chart going all the way back to a flow chart going all the way back to the 1800s, and the progression of how things have developed, over the last several centuries. Early 1800s. Really, there weren't very many options, but actually just sacrificing the artery going to the aneurysm. Okay, so if you imagine, if you have two pair of blood vessels called the internal carotid arteries that go up on either side, they supply the vast majority of the brain. If there's an aneurysm coming off of the internal carotid artery, back in the day, there was no other option but to just sacrifice the entire vessel. Okay, as you can imagine, that probably led to a high degree of strokes happening. Okay, because you're blocking up blood flow. But back then, that was an acceptable outcome, because having what we call a stroke due to sacrificing a vessel was better than a ruptured aneurysm, because that has such a high fatality rate. As the years went along, the advent of what we call conventional angiography to be able to diagnose these aneurysms a little bit better, that led to what we call development of open surgical clipping. Okay. And I'll talk about that in a little bit here. And that's still a widely used form of treatment that I still use, and other vascular neurosurgeons across the country. It's still a very powerful tool for treating aneurysms. Then as we forward into the late 1900s is when we have the advent of endovascular techniques. Okay. So those are the ability to treat aneurysms through the blood vessel. It's sort of a minimally invasive approach, right? And so instead of having to do, a scalp incision, a craniotomy, a big open surgery, nowadays we're able to treat a lot of aneurysms with a, basically a couple millimeter incision in the groin or in the wrist that allows us access into the blood vessels, going all the way up and treating aneurysms that way using a variety of different tools. So quite remarkable where the technology and the advancement has come. Initially started off with deploying what are called coils. Coils are, basically these metal nowadays. There's mostly platinum coils that go within the aneurysm, and it prevents blood from getting in. Okay. Over time, that's led to the development of what we call this flow diverter technology, which it really has become the mainstay of a lot of the aneurysms that I treat. In this day and age, it's truly revolutionized how we manage these aneurysms, and I'll go over that in a second here. In the office setting, obviously, I'm dealing with a lot of unruptured aneurysms, and that's where we have the discussion about, how do we quantify the risk, weighing against the risks of doing any procedure versus the natural history. Natural history being what are the rupture risks of such an aneurysm. Okay, and I'll talk about that in a second. A ruptured aneurysm, as I mentioned, that's an emergency. That's something that's seen in the hospital setting. By every ruptured aneurysm that makes it to the hospital that we believe we can help the patient, and that's by a large vast majority of them, they need to be treated. That is an emergency situation. Within 24 hours, I do end up treating these aneurysms. And the method of treatment, whether I decide to do the open surgery or treating it endovascularly, depends on a variety of factors. The degree of hemorrhage, the aneurysm shape, where it's located, how easily I can get to it surgically, and the status of the patient, right? The ability to tolerate, minimally invasive approach is generally better, right? As opposed to doing a big open surgery. So if somebody is already quite sick and I'm worried about their ability to handle a prolonged, surgical case with anesthesia and all these things, then I generally tend to elect, treating endovascularly. But it really depends on, shape of the aneurysm and my ability to treat it, give the best possible outcome on either way. And this is just a diagram here. It's a 3D reconstruction, what we call it. If you see an aneurysm that sort of has a broad base, that means it's what we call a wide neck. Neck is the part of the aneurysm that's directly adjacent to the blood vessel itself, and it's not very high, so it's shallow and broad. These are actually more challenging, what we call endovascular cases. As opposed to, something that's a bit taller, these are better suited for endovascular cases because whatever, I put in this aneurysm, whether it's a coil or anything else, it has more of a chance of actually staying within the aneurysm as opposed to being shallow and broad, and that becomes a little bit more of a challenge. And so, for these wide-necked, shallow ones, sometimes doing an open surgery can offer a better result. Okay. And when we talk about unruptured ones, then this is a discussion that we have on an elective basis, weighing all of those things that I mentioned earlier, into account. This is just one of the tools that I have, and this is a compilation of multiple large multi-center studies that have come together with these risk factors that help us basically quantify, well, what is the risk of this particular aneurysm rupturing? Okay. This is not the only thing, but this is a pretty powerful tool. So certain things like population, okay, ethnicity. Finnish people, for example, have a much higher risk than being North American. History of high blood pressure, particularly uncontrolled high blood pressure over years, adds a point. Age adds a point, and size of the aneurysm. This is a big thing, right? The bigger an aneurysm is, you imagine that weak point. The bigger that weak point is, the more likely it is to rupture. Earlier subarachnoid SAHs, means subarachnoid hemorrhage from another aneurysm, is also a risk factor. So if somebody has had a prior rupture, prior aneurysm that's been treated, and a new one comes up over years, and these are patients that we follow pretty closely. Those generally I will also recommend treatment for, because they've already demonstrated that they have a higher propensity for a bleeding aneurysm. And site of the aneurysm is also critical for me as well. Depending on the location, certain ones just have a higher risk, and that's sort of a discussion that goes into it. And you can imagine the more points you have, the higher the cumulative risk. Okay. Now, the one thing that this score doesn't take into account is the morphology or the shape of an aneurysm. Okay. Going back to this here, an aneurysm that's taller, okay, tends to have a higher risk of rupture than something that's a little more shallow. And something that's what we call, for lack of a better term, lumpy and bumpy, right? So it's not as smooth, but it's irregular on the edges, that has a higher risk too. So all of these factors really have to, be taken into account before I say, hey, this is something that I would recommend treatment for, or this is something that we can safely watch. Okay, so like I mentioned, one of the oldest forms of treatment, which is still a very, very powerful, tool that vascular neurosurgeons have, is called surgical clipping. Okay, and that refers to doing an open surgery and coming from the outside in. So if you have, if you look at this cartoon here, you have this aneurysm, and this is just it's showing the aneurysm rupturing. And so clipping refers to coming from the outside in and placing this clip, traditionally made out of titanium, across the neck of the aneurysm, and that basically shuts off any blood going into it. Okay. This is still a very powerful tool, and for certain aneurysms, this actually offers a much better result. And I'd say probably I'm treating aneurysms in this day and age using this technique maybe 10 to 20% of the time. Okay, and so it is still a very, very durable. It's still the most durable long-term treatment that we have. When we talk about treating an aneurysm, they still need to be followed over years and years, as there can be recurrences. And this, is still a very, very powerful tool. So when I see my patients in clinic, I, in depth review all the anatomy with them, and I tell them, hey, in my hands, I think I can give you a better result with one of these two techniques, and this is still a pretty powerful one here. But generally speaking, if I can give a good result treating it through the more minimally invasive approach, I tend to do that. It's a faster recovery, usually just a overnight stay in the hospital. Everyone goes home the next day, and people just tend to recover a little bit better. Okay. This is an example of one of my surgical cases. This is a big aneurysm you can see here. Okay, very large saccular aneurysm at a location called the middle cerebral artery. Okay, there's a middle cerebral artery on the right side, on the left side, and this was on the right side here. You can see how large it is here. And this was actually one that was not a good endovascular candidate based on the shape, based on the blood vessels coming in and out of it. This would have really not been a good case for me to do in the cath lab. Cath lab meaning cases that I do endovascularly. And so, I had a discussion, and I told them I can give them a much better result, more durable result by doing the surgical clipping, and that's what we elected to do. And this is the angiogram immediately after. You can see that this was where the aneurysm was originally, and I don't know if you can kind of see, but the clips are right here. And this took about 3 or 4 clips to be able to reconstruct it and keep all the blood vessels open. And then we kind of shift gears to the other end of the spectrum, the endovascular devices, okay, and techniques. The first technique really developed was that what we call coiling, primary coiling. So that basically refers to treating going in through the blood vessel itself, through a variety of catheters and wires, and deploying these coils within the aneurysm, and that prevents blood from getting in. Okay. Now, what happens with this primary coiling? Now, generally, this is really reserved for what we call, in the ruptured setting, if it's a bleeding aneurysm, because just putting coils within the aneurysm does not require any blood thinners to be on board. Okay. So it's a very good, immediate, effective tool to prevent an aneurysm from re-rupturing. Okay, so when somebody comes to the emergency department and they have a ruptured aneurysm, it's not that the aneurysm is actively bleeding, because unfortunately, when it's actively bleeding, they don't survive. Okay, because that's a rapid progressive rise in intracranial pressure. But what happens in most situations is an aneurysm ruptures, and then sort of this blood clot forms at the rupture site. Okay, now those are very tenuous; they're very unstable. Okay, they have a high degree of re-rupturing, and a re-rupture is about a 95% fatality. So we almost try to treat within 24 hours to prevent a re-rupture from happening. In which case, a primary coil is a very good option, where I basically go in, I put some coils in, it protects that rupture point. Okay, but what happens is, if you imagine you put these coils in here and there's a jet stream of blood, what it does is it basically compacts those coils, and so over time, over months to years, those coils, instead of covering this whole area, they're going to be pushed to the top. Okay. And so what that does is it leads to recurrences of aneurysms occurring at the neck or the base. So a lot of times, especially in the rupture setting, if I need to put a couple coils in to protect it, then I will bring them back at a later point and provide some additional protection. And what does that protection look like? There's what we call stent assist coiling. Okay, that basically involves, in addition to the coils, you put a stent across the blood vessel itself, that what we call the parent artery. And if you can imagine, by putting this in here, then you can really pack this really tightly without worrying about the coils coming out. Okay, so it's a protective thing. Okay, now, but anytime we put a stent, it's a metal stent inside a blood vessel, we don't want the body reacting against it. So that's why blood thinners are on board. Very important. Okay, aspirin and Plavix are the two most common ones. Those are the same ones used for people who have stents in their heart, okay, or stents elsewhere in the blood vessels. So similar idea. So in the elective setting, I almost always prefer to do a stent coiling or what we call a flow diverting stent, because this offers a more durable long-term again, as long as patients don't have any what we call contraindications to blood thinners. Some people have had, some patients can't tolerate blood thinners because of nosebleeds, GI bleeds, other things that may prevent them. In which case, the open surgery can actually be a good option. So, the stent assist coiling it reduces the recurrence rates long term. Okay, and this has really been in the last, I would say, 15 years or so, where this has become a very popular form of treatment, very effective. And then the other, even more powerful than that, is what we call a flow diverter. Okay, a regular stent, an intracranial stent, only has about 5 to 10% metal coverage. Okay, so the pores between the metal wires are fairly big. A flow diverter has about 30 to 35% metal coverage. Okay, so basically what this is doing is what the name would apply. It is diverting blood away from the aneurysm. Okay, so when we put these flow diverting stents in, a lot of times we don't even need to put coils in, because what happens is blood going in here, it's basically the stent itself prevents blood from going into the aneurysm, and it slows it down from coming out. And so whatever's in there will actually just clot off and thrombose over time. And so this is a very, very powerful technique. This is, like I said, is how I'm treating the vast majority of the aneurysms in this day and age. And this has really been over the last 5 to 10 years. The closest thing that's really come to long-term durability compared to an open surgical clipping. So it's a very powerful technique. And big aneurysms, very large aneurysms that back in the day would require, we call bypasses, where the connecting, sacrificing blood vessels or connecting two blood vessels together because there was no other good technique. These flow diverting stents have truly revolutionized, turning a 10-hour surgical case into an hour. And so it's a pretty powerful technique, but it does require blood thinner. So that's one thing that is important, that the patient's ability to tolerate that. This is an example of one of those flow diverting stents in adjunct with coils. This is an angiogram here, this large, you can see balloon shape saccular aneurysm. And basically I treated this by putting a stent that went inside the blood vessel itself and a bunch of coils that went inside the aneurysm itself. And that has completely gotten rid of it. This is another technique. Oh, sorry, I mentioned this other diagram here. So the other thing is we call a balloon assist coiling. This is also similar to primary coiling, but what it does is it allows by inflating a balloon. So instead of putting a stent, that's sort of a permanent thing that goes in. One of the other techniques I can do is while I'm deploying these coils within the aneurysm, and you don't want these coils coming back out, right? And so by putting a temporary balloon, inflating a balloon across the neck, it allows you to pack things a little bit tighter and prevents the coils from coming out. This is also generally reserved for the ruptured cases where I can't put people on blood thinners right away. Okay, so it can be a powerful technique. I generally do not, in the elective setting, if I can use a stent or a flow diverting stent, I almost always prefer to do that because that generally tends to have a much better result. And I reserve the coiling or the balloon assist more in a rupture setting where I can't safely do blood thinners at the moment. This is a even more recent device here. These are called intrasaccular flow diverters. Okay. So instead of having a flow diverting stent that's going inside the blood vessel itself, okay, what we're basically doing is putting these high metal coverage, essentially these baskets, inside the aneurysm. Okay, so what it does is it also has a similar effect by slows down the blood coming into the aneurysm, slows down the blood coming out of it, allows for thrombosis to occur over time. This is a very powerful technique as well for what we call those wide-necked aneurysms. Okay, because these are devices that there's a lot of different sizes to them, and as long as they're sized appropriately, they can sit pretty nicely in these aneurysms, and they're generally not going to come out. You're not worried about them, causing damage to the surrounding blood vessels, and they don't require blood thinners, which is the other positive effect of these. So this can be used safely in ruptured settings. Okay, in addition to that primary coiling, this can be used in cases where aneurysms are so deep that it does carry a very high surgical morbidity. Okay, so there are certain aneurysms in the brain that in this day and age, very, very few people would actually try to target them surgically because they're very deep and they cause and there's a significant amount of risk. So in those situations, these what we call intrasaccular flow diverters can be pretty powerful. This particular one is called a woven endo bridge. It's called the acronym WEB is the acronym, and this is just one of many now that are coming out on the market. Okay, there's a lot of these. There's a lot of technology and science and going into developing these intrasaccular devices because some of the hardest aneurysms that we have to treat are ones that have a wide neck, right? Because they do require all of these adjuncts, and they may require stents, and they may require blood thinners. Okay, if you imagine, if you had this balloon-shaped aneurysm, but it has a very narrow neck, you can be pretty safe with putting a lot of coils within the aneurysm, and you're not worried about them coming out. But if it's a wide neck thing, then we have to deploy a lot of these other techniques. Surgery is still a very good option for those wide necked ones, and that's why there's been a lot of push in the last 5-10 years to develop these intrasaccular devices that potentially don't need patients for me to do the big open surgeries, and I can deploy these devices in a fraction of the time and doesn't require blood thinners. Okay, so there's a lot of positives to this. Now, we're still in the infancy of a lot of these devices, to be honest with you. The recurrence rates are still a little bit higher than I would like. But as a long-term data, the next 5, 10, 15 years comes out and the devices get better and better and better, I'm sure those numbers will come down. So basically what that means is anytime I, deploy one of these devices, it does require follow-up. Okay. So that means, 6 months, I usually either bring people back for an angiogram to see how things look, or get another variety of what we call non-invasive scans that includes MRAs, CTAs, to try to get an idea of, well, okay, is the aneurysm still shut down? Okay. Because if I notice that things are growing, or at the base they're growing, things are starting to compact. So similar phenomena can happen with these devices. That can happen with coils. There can be, if you imagine there's a jet stream of blood pushing at these devices, there can be recurrence that happens and compaction that happens, and so these do require a little bit more of a closer follow-up. The benefit of doing this stent that goes inside the parent artery itself is that and I usually my protocol is might be slightly different than other people, but I think this is pretty uniform, and this is how I was trained. But generally 6 months after placing one of these flow diverting stents, I bring people back for an angiogram. Okay, if the aneurysm is completely gone, okay, that blood vessel is completely healed, it's not coming back, and that's a benefit. So it doesn't really require long-term follow-up past that point. Okay, now it does take some time for the aneurysms to completely heal. It can be longer than 6 months, it could be longer than a year, and I have some patients that I'm bringing them back for their third angiogram now to make sure that it's completely gone. It can take some time. Every patient is a little bit different, and so it does require some follow-up. But once you notice that it's gone, then we're good. We don't need to essentially follow, because that blood vessel is completely healed at that point. So, all right. This is an example of that intrasaccular flow diverter here. This is an angiogram showing this aneurysm here. This is a middle cerebral artery aneurysm, not quite as big as the other one that I showed. So this was this was one where I basically had a very similar discussion, and the other one I had basically said, hey, I think there's no good endovascular option. I think surgery is the best option for you. In this situation, I had it was sort of equivocal in the sense that we talked about doing an open surgery that would have given her a very good result as well. But I also felt that, hey, this is actually a really good case, for doing this intrasaccular diverter. And we talked about all the options, the risks, the alternatives, everything, and and the patient elected on proceeding with this technique here. And so basically, what happens is, if you see that this is how the aneurysm looked after deployment, you see how this is contrast shows up dark on an angiogram, and that's what we're seeing here inside the blood vessels and the aneurysm itself. So you can see that the contrast is already starting to slow down. Okay. And this is, I don't know if you can kind of make out the shape, kind of looks like a little basket here. Okay. And this is one of those that in 6 months, when I brought her back, everything looks good. The aneurysm is completely gone. It hasn't come back. But in these situations, because this is not a stent within the blood vessel itself, this does require a little bit longer follow-up. So I will continue to probably follow this for the next, 1 to 2 years to ensure that nothing is really coming back. So, and like I said, there's a whole variety of new ones, that are coming out. The web device is the one that I use more frequently. That's the one that's been tested the most, with fairly good data. So, but there's centers across the country that are certainly trialing, these new devices. And the aneurysm space is one of those where we are always trying to advance at a pretty rapid rate. And this entire field is called neurointervention, or we call neuroendovascular. It is probably the most rapid, if not one of the most rapidly growing fields of medicine. And it's truly revolutionized how we think about and how we treat these things, because it is such a major event that when an aneurysm does rupture. So we try to stay ahead of these things as quickly as possible and give the most durable, best long-term outcome. Okay. That's what I got.
So thank you, Dr. Chugh. So I have a couple of questions that came in. Can you share a little bit more about what the recovery looks like after you put in a stent?
Yeah. So, and I'll talk about recovery for all the different options, right? So, the endovascular, can you go back to the PowerPoint?
Oh yeah, hold on. I'll put it back up here. There you go.
Yeah. So, any of these options here, it's usually just an overnight stay in the hospital. Okay. For the first, and generally, like I said, most of the times I go into what's called a femoral artery in the groin. Sometimes through the wrist, the radial artery in the wrist. It's usually about a 2 to 3 week recovery in terms of where the restrictions are in place. And what that really means is, no, I don't want patients bending, twisting, lifting. That's really just to let the very, very small incisional site heal. Obviously, there's healing that's occurring inside the artery itself, because you imagine, there's an arterial puncture, right? There's catheters that go inside the artery itself, and we use a variety of closure devices to seal up that hole. But recovery can take a couple of weeks, right? And that's really to let the groin or the wrist, completely heal. Okay. And so 1 day in the hospital, and then we're looking at a couple of weeks, and by and large, most people are back to their normal activities, I would say between 3 to 4 weeks, with really no restrictions, flying, activity, golfing, all those things. If there's blood thinners on board, then I generally, will caution to be a little careful once you're getting back into the thick of things, because they are powerful blood thinners and they remain for 6 months. Okay. Like I said, that's why I generally bring people back for angiograms in 6 months. If the aneurysms have completely healed, then blood vessels have healed, and they're all gone, then I take people off of the stronger blood thinner, which generally tends to be Plavix, or Brilinta is the other one. Aspirin continues for life. Okay, but the stronger blood thinner, as long as things look good, will come off at the 6 month mark usually. And then when we're talking about the open surgery, the clipping, that's expectedly a longer recovery. So we're looking at probably 2 to 4 days in the hospital, and then probably about a 6 to 8 week full recovery. And that's also to let the incision heal. The restrictions will remain for a little bit longer. No bending, twisting, trying to lift anything above your head, just to let everything internally heal.
So, Dr. Chugh, what is there a risk of having an occurrence, a reoccurrence, or maybe an aneurysm, maybe in a different spot? If they've had one, if you've been able to surgically take care of one, would you end up seeing somebody down the road for another aneurysm? Like, what's the risk of that? I'm sure people are scared, right? When they've had one, am I going to get another?
Yeah, that's a great question. So, yes, if somebody has had an aneurysm, then the general risk of another one coming up at some point is higher than somebody who hasn't had an aneurysm, right? So, whether it's a treated aneurysm or one that we're following and not, basically doing surveillance imaging if it's small and the rupture risk is low. Yeah, so whenever we get these scans as a surveillance, we're evaluating all the blood vessels, right? So we're keeping an eye on the previously treated one or the small one that we're following, and we're also checking for any other ones that may pop up, right? So, things like family history and a previous rupture and all these things are higher risk factors. Now, aneurysms are generally not something that people are born with. Okay, they develop as the years go along. Okay, this is a little bit different than another entity of a vascular disease that I treat, what's called an AVM. It's called arteriovenous malformation. That is something that people are generally born with. An aneurysm is something that develops over time. So, the risk factors that I mentioned, obviously, you can't control family history, you can't control genetics. What we can control is high blood pressure and smoking. Those are the two biggest risk factors for aneurysms forming, growing, and bleeding over time. And the recurrence rates, for a previously treated one, so for example, the primary coiling that I mentioned, that has a fairly high recurrence rate, probably upwards of 20 to 30%. Okay. Adding a stent to it, we're dropping that down to probably 5 to 10%. The flow diverting stent, we're dropping that even lower. Okay. So maybe, less than 5% recurrence rate. So surgically clipping it is still pretty low recurrence rate, probably 1 to 3% or so. We're looking at, 10 to 15 year rate here.
And if you had you can get an aneurysm in other places, right, other than your brain. So does that increase your risk for getting a brain aneurysm down the road?
It can. Now, if it's an aneurysm elsewhere related to something in the family history, or there's certain autosomal or genetic disorders that do kind of make us a little more keen to probably screening the head as well. Yes. But, for example, something more common is what we call an abdominal aortic aneurysm, right? And so the risk factors for that are actually pretty similar to developing an intracranial aneurysm, high blood pressure, smoking, things like that. Now, from a screening standpoint, we generally don't screen. If you have an aneurysm elsewhere in the body, that's not enough of a trigger for us to screen the brain as well. Okay. But if you happen to have an aneurysm, if there's 2 or more first degree relatives, okay, that have had an aneurysm, then I recommend the entire family get screened. That in and of itself is a big enough, very big risk.
And you do that through angiogram, correct?
Angiogram is more of an invasive. It's sort of the gold standard, certainly, to evaluate. And any aneurysm that I am recommending treatment for, I always get an angiogram first because it gives me the best view. It allows me to come up with the best treatment plan. But if we're just screening, then we do that with non-invasive scans. So MRIs, CTAs, especially, for example, if somebody comes to my clinic and they have an aneurysm and their mom also had an aneurysm and we want to get their kids screened, generally we'll start with something that doesn't have radiation, right? So we'll start with an MRI, MRA, when they turn 18 or something along those lines. So, but yes, the screening process is generally for a non-invasive study.
Okay, great. I want to thank you so much for being here, Dr. Chugh. I'm going to turn it over to you to answer any questions in person, and I will wrap up with our online audience. Thanks so much for being here.
No problem, my pleasure.
Thanks again for being here today. I look forward to seeing you tomorrow. We will be having Dr. David Teeple here from Center for Neurosciences. He'll be recognizing stroke symptoms, fast action. That is on Wednesday, March 19th at 3 p.m. If you're interested in that class, please give us a call. The phone number is 520-324-1960, and we'd be happy to get you registered for either online or in person. We will see you again soon. Thank you.